This is your co-host, Wes Lyon, and with me is my co-host, Dr. Scott Menaker. Scott, welcome back to the show.
Hey Wes, good to see you today, and happy to be here for another chat with our young dentists and aspiring dentists out there.
Absolutely. I'm really looking forward to this episode, although I don't know much, because last episode we talked about, follow the procedures, make sure you're doing things correctly, take your time. But that goes completely against our advice of produce a lot of dentistry so that you have a production record and you can buy a practice or become a partner. So today I really, you're a clinical dentist. I'm not. I wanted to figure out, hey, what are some tips, tricks that these dentists can use to really, not cut corners on a procedure, but what's a better procedure that you found throughout the years that can really help them, not only be more productive, but also help the patient have a much, much better experience. So I'm super excited for this
Yeah,
episode.
and we've got a couple things to talk through, and we're always we obviously want to get out and we want to be faster and do more, and obviously, especially as an young associate in a practice, you're going to be paid on production, and so
They
you
don't
want to.
just pay you hourly.
Well, you might get somebody who'll do that, but most people are going to
Probably
get
not a
paid
high.
probably not that much. No. And so now, and again, we don't want you to, we're not saying, listen, cut corners, do things the wrong way because you want to make more money. We'll tell you the absolute opposite. Do things the right way. It'll all come back to you. But we want to talk through a couple things today that I think will help you be able to do more dentistry, do it more efficiently, more effectively.
So I thought
Get things more done.
one of the coolest ones as we were going through this was the anesthetic, which, I don't really know why or how. This is the first time anyone explained to me, but, 15 years ago, got dental work done and you did a really good impression of it. But, you walk out of the dentist and the whole left side of your face and tongue is lit up and, you can't really talk right for a few hours. But I was
You can
recently
mumble.
you can mumble,
And you
but
notice, everybody loves to make fun of dentists and do parodies on TV and comedy sketches or whatever about you've been to the dentist and you're going to talk. And anyway, uh,
Well, no, I had no
yeah.
idea. I had never really thought about it. That hadn't happened to me recently. And, I was just in for a perio procedure that it was a kind of more minor one. But, I went in there and numbed me up and started doing it pretty much immediately. I didn't feel anything. I got out of there really quickly and was able to talk. And I just really hadn't crossed my mind. So, walk me through. We were having a fascinating conversation about it, but walk me through, what you do, how that works, and, what these dentists can learn because to me, you were talking about it saves you time and really helps you from a clinical standpoint. I was sitting there in my mind going, oh, I loved going in there and he started immediately and I walked out and could talk.
Yeah. Yeah. And I think the piece that you really hit on there is you can do things clinically that are going to be mutually beneficial. It's going to be better for me as the clinician, but it's also going to be beneficial for the patient. And I always like to view everything that I did in that view, because everybody's trying to, you're going to be going to CE courses for the rest of your career, and everybody's got their great thing that they're going to do. And it's going to save you 30 seconds here and 40 seconds there. And next thing you know, you've done a crown prep in 15 minutes and they're out the door. And there was a guy years ago, this is going back 20, 25 years ago, who was selling videos on how to do a 15-minute crown prep from start to finish.
Mm.
And I was like thinking to myself clinically, I would not want to be sitting in the chair after watching this video, watching what this guy did in 15 minutes, because it was just, he was pretty much beating the patient up to get it done. So we don't want to talk about that, but one of the things that I learned early on, and we'll talk through two pieces here about anesthetics, is a different kind of syringe called the intraligament syringe, or what I call the perio press. And we're also going to talk about the anesthetic itself. People will still come into your office today and says like, I don't like that Novocaine. Well, Novocaine hasn't existed in 40, 50 years. We've been using lidocaine.
Yeah, but I think it's a line in a country song, so everyone knows it.
But the lidocaine has kind of been the standard of, and whether it had epinephrine in it or not, which helps it last a little longer or not. And patients are going, patients will come in and say, well, I'm allergic to that anesthetic. And It made my heart race. All that was you got a little bit of the epinephrine in the, from the anesthetic, got into their blood vessel. It lasts for about, usually a minute and a half, 2 minutes maybe, but it's not they're allergic to it, but people will tell you that they are. But over, the last 10 or so years or so, the development of articaine, has been kind of, for me, was kind of a somewhat of a game changer. Um, the problem with, I don't want to have to, I don't want to go into a big anesthetic anatomy thing, but basically, the upper jaw always numbs up pretty quickly. You could do an infiltration right in front of the tooth you were having worked on, similar to where you had your gum graft. They just inject it around that site, and it numbs that up.
Now, is that just gravity related?
No, it's related to the anesthetic going in through the porosity of the bone to getting out to where that nerve enters the tooth.
My simple mind was going, well, the tooth's below the injection site. It's going
Well,
down.
you're just gonna kinda put it in a place kinda where the nerve is closer to it. Um, but in this case, so articaine really was a game changer in that it allowed us to start to do some infiltration on the lower arch. Um, I I really was trying to think back to the last time that I gave a mandibular block. One of, something people will say 80 to 85% successful. You wait 5 to 10 minutes. Most of the time, you numb the patient. You come back 10 minutes later and they ask you the question, "Hey, Wes, is your tongue feeling numb?" And when you go, "No, I can still feel my tongue." What do they do? What do we do as a dentist? We gave you another injection and we let you wait another
10
10
minutes.
minutes or so. And we hoped we got it in a little different place and that it worked. Well, I just hated the idea. One of I was busy when I was a solo dentist, and I was busy certainly when I had associates. I had built a very nice practice. I just didn't want to wait 10, 15, 20 minutes because we were scheduling me based on 5 or 10 minutes to get five. Literally for me, it was 5 minutes. And so articaine really became a game changer because I felt more confident when I used the periopress or the intraligament syringe, and I'll talk about that in just a minute, because one, it provided more profound anesthetic. It worked much quicker. And then two, it didn't sometimes last as long post-op. So the patient would go, "Yeah, I wasn't numb for 4 hours," which sometimes patients would complain about. Um, and the way that I delivered this, was in this periopress or this intraligament syringe. I would advise you go on, go Google it, go on YouTube. There's bound to be plenty of videos on this, but I started using this, God, probably 35 years ago. We were still using that with lidocaine. Um, but basically what you're doing is you're putting a needle into the ligament space around the tooth. So say we're on tooth number 19, this lower molar, you would put that in the mesial and on the distal, on either side of the tooth, into that ligament space, and you would inject the anesthetic, probably we call it three squeezes, which was like two 2/10 of a milliliter of anesthetic under pressure into that space, and the anesthetic would diffuse to the bottom of the tooth, to that ligament space, to the end of where the nerve entered the tooth. Now, in many cases, that was successful on the first go. Sometimes you would have to go back. And so what I ended up doing over these last probably 10, 15 years was I would infiltrate with, especially on a molar, coming on a premolar forward, I would just infiltrate, wait 2, 3 minutes, and I'd pick up my handpiece and go. And they're profoundly numb. They never felt anything. I always said to my patients, "Listen, if you feel anything, let me know." Now, you can always kind of see if they feel anything. Their eye starts to quiver a little bit. They're trying to be tough because they don't want to say something, but I kind of stop and go, "I know you're feeling that. I'm going to give you just a little bit more." And again, when I go in to give a little bit more, I'm not waiting. I'm going into the ligament space. I may be infiltrating a little more, and I'm going immediately. And over time, I've done this for taking teeth out. I've used it on first, second molars. It maybe we've done it on third molars. It's not quite as successful, um, just because you can't infiltrate that far back. But it really became a game changer. I've done placed implants this way. I don't, and I just have never. I've not given a mandibular block in probably 15 years.
That's awesome, and I can tell you from the patient perspective, I didn't really know other than, my periodontist is clearly doing that now that you tell me about it, but let's say you're out there and, I don't know, do dental schools, do they train each and every way? Do they just how do they get the
Yeah, no,
training
and
on
I would
this?
imagine some are gonna be teach you that and some are not. I'm sure they're using articaine, as an anesthetic today in schools. Um, the PerioPress might be something that's completely new, but I learned it kinda cold turkey almost day one from school, and it really looks it almost looks kind of like a gun because you're applying it with pressure. So you have like a squeezing of your hand against this type. There was one that was designed, it was like a little bit of finger pressure. It didn't seem to work very well. It did work well in my hand, but it can be a very good either main form of anesthetic and way to deliver it, or it becomes an adjunct if you feel like you still want to give a block, you're doing 3 teeth and you want to do that, and you got one tooth that's maybe a little not quite getting numb. You just go back with this periopress, and it was great. And patients would always say to me, "It is so good that my tongue is not numb." Now they were pretty numb out here. But if their tongue wasn't numb, they could speak normal. This seemed to dissipate much quicker. Um, and so that was really probably one of the biggest game changers. And it made, again, I waited 2 to 3 minutes. I wasn't waiting 10, 15 minutes.
So you're getting a better patient experience and you're depending on how many times it takes to get them numb, you're potentially saving 10, 15 minutes.
At least. Yeah. And again, for somebody who just didn't like twiddling their thumbs, waiting around, and then hoping that they were numb, I know that I was going to be probably 98% successful. And again, every once in a while, there's going to be a tooth that's just, it's going to be hard. And sometimes you'll go back. I would have to go back 2 or 3 times. And maybe the patient would have a little soreness postoperatively around the gum. So, in conclusion with talking about this, I just encourage you to explore, and there's lots of things out there. I never wanted to go buy all the expensive syringe systems that cost thousands of dollars to do that. Go slow, know where you're putting your anesthetic, use articaine, use the periopress, and it certainly made me much more efficient and much more effective.
Oh, that's awesome. Well, that kind of brings us into the next one I wanted to bring up. And this one, I think the story is a little unrelated, probably to the answer that you have here, but it's kind of from the patient perspective, what you can hear about and what your reputation can be if you do screw something up. So I had my wife's friends all call me because I'm somehow the dental guy, even though I'm not a dentist. And, my usual advice to them is here's 3 dentists that you can go see that I know will give you a very honest opinion. However, once somebody called me and they had a failed crown from years before, and somehow that turned into a lost tooth. And I'm not real certain the tooth couldn't have been saved. I am certain that they were going to a dentist off of who took their crappy insurance. But it just kind of led me to believe, that dentist that put that crown in there, whether or not it was their fault, whether or not anything went on, they've now got a crappy reputation with a group of females running around Charlotte, whatever,
Right, for
but
sure.
for better or for worse, or whether or not it was their fault. But it just kind of reminded me of, hey, every now and then things do fail. We talked last week, kind of, relating it to manufacturing processes with bonding, a little bit relating to fillings. But, fillings and crowns are going to be a lot of what pays the bills for these younger
Absolutely.
doctors. So, hey, you have any tips out here on how to make sure that, their crowns aren't failing and, maybe not even just say, hey, how do I make sure they're not failing, but Do you have any tips, tricks, or ways that you can really help these young dentists do a crown more effectively for efficiency and for the patient experience with that crown? Because I've got a couple of them and I don't really like that.
Yeah, right, and, and the key that Wes is talking through is people are they're gonna whether it's your fault or not, they're gonna talk, and so the key is how do you make sure that you're trying to do things the right way to minimize failures that might have been caused from our end, and again, we got them, and you'll look back on things, later in life. Hopefully, you learn from the mistakes, but, uh, the thing we're gonna talk about in terms of, the crown preps, and most students today, especially coming out of school, just are not getting the enough clinical experience doing them in schools. They're having, and especially on live patients, they're doing it on dentiforms and mannequins, and I'm sure they're doing them digitally now. And there's just, but doing them the right way is going to be super important. And I tell you, the thing that really helped change things for me is when I became a CEREC doctor. And basically, we're doing everything on a computer and using materials that were different. Everybody thinks, well, today we can make a crown out of zirconia, and we can make it a half a millimeter thick, and it's going to work. Well, you can make anything you want. The question is, how long is it going to last? And that goes to your story. I don't know if, we don't know. The crowns fail, teeth fail for lots of reasons. I just never wanted it to fail because of something that I did. And so we want to encourage you to do that. So one of the things that I really
It sounds like, bring it back to what I can relate to, cars. I have certain car manufacturers that I think have planned obsolescence, meaning they know the car is gonna fail at some point.
right.
And I always look to buy one from a manufacturer I think looks out for longevity. So we're really looking at this in my mind, if I'm translating this to plain English, is how do we do the procedure so that we're doing it for longevity,
Yep.
quality, that we're not cutting a corner? Because I think I've never really thought through the clinical side of this. I think through the patient experience, but if you're going to one dentist and I see it all the time where if you're in network with some providers, and this is kind of clicking in my brain from what dentists tell me when I meet with them, if you're in network with certain providers, I hear that, hey, I can't actually do a crown and make money off of it because the only way to do it is to use cut rate materials. So what we're really talking about is, not only is this going to help them make it a much longer lasting, but it's going to build the skill set where eventually they don't need the insurance to drive the patients.
Absolutely. Right. We're always going to advocate do things the right way, and it'll all come back to you. It may not happen the first year, it may not happen the second year, but if you set your plan out the right way, you'll get there. And so doing crowns, the one thing that I found, and I would encourage every dentist, is to use what we call these depth cutting burrs. So when you're preparing a crown, you've got to have a certain amount of material there for that crown to be clinically successful. And the biggest thing that I think the biggest failures that occur are going to be because a crown cracked, broke, the porcelain chipped. And in many cases, if you really go look at it, it's probably because the tooth was underprepared. They didn't do it. So, you pick up a burr today, you pick up a diamond burr and you cut some depth cuts in it. And then you go on and you do all your preparation. And then you look at it and you kind of think, well, I followed those rules. It's going to be just fine. Well, what I found over time is the only way to really, and it sometimes still didn't work, but the way to guarantee that I had enough reduction was to use these occlusal depth cutters. Um, a number of different companies make them. Meisinger was one of the ones I used to get them from, but a number of companies make these. But basically, the first 2 millimeters of this burr was diamond, so that you could go in and cut through your depth, and then it flared at the top, so that when you hit tooth structure with that, it didn't go any deeper. It prevented you from going further into the tooth. And if you then went mesial to distal, and then I would go in between, I would go up the cusp tips. If there were 2 cusp tips, great. If there were 4, and I would literally use that to help reduce my whole occlusal surface. And if you then took a look in, and I would originally would start to kind of look in the mouth now clinically and have the patient close, you go, wow, I actually have room to restore it. Now, especially using a CEREC where I'm making the crown in my office. And there's a lot of different systems out there today. I just, almost 20 years ago, that was the only one and obviously the best one, um, and continues to be. But we were using materials that were much
And
more.
are we sponsored?
Well,
We're here, Sirac, if you'd like to call us.
we'll talk to them. And again, today there's lots of other companies out there, but at the time they were the one, they were the leader, and that's there was really nobody else at the time. Um, but the materials that we had to use then were much weaker than the ones that you could use at all of these same day, in office milling units today. You can use zirconia in these units today. You couldn't back then. And so it was really dependent on if you prepared the tooth correctly, it would work. If you didn't prepare it correctly, failure time. And I had initially too many failures because I was learning a new system. But the same would even apply to porcelain over metal. It'll still apply. You can still fracture a zirconia crown, but you want to make sure that you're following the rules in a way to have enough thickness. Many crowns that you'll redo today will be because the porcelain broke. And I would venture to say the overwhelming majority of them are due to they were underprepared back then. And the lab, again, your lab can make you something to go in there. That's not the answer. It's what is it going to look like 5 years from now, 10 years from now, 15 years from now. And I still have some of those crowns I did 15 years ago. They're still there. I broke some originally, but I learned some lessons because I wasn't probably following the rules.
Got it.
So that was really the biggest one. And many years ago, I learned a little tip and trick from a dentist at a course. Said, I hate using a diamond to go around the facial, the axial surfaces. So going around the facial and the lingual surfaces of the tooth. I want to get rid of all of that enamel, which is the hard stuff. The dentin cuts much easier, and I would rather cut the dentin with a diamond. And so he advocated using a carbide burr. And so what I started experimenting with was going into that DEJ. I know you don't know what that means, but Wes is like got a puzzled look on his face, but it was just that junction between the enamel and the dentin. And then going counterclockwise, I would just literally peel the enamel off the tooth.
Now, question for you. So you've got the first one that's got the 2 millimeter diamond, and that's the one that's going to cut your depth,
on
right?
the biting surface of the tooth.
Right now, do you use that first?
Yes, I did
Okay.
that first. Yeah.
So you're going to first cut to the depth, and then instead of using diamond, you're going to use the carbide.
To remove the remaining enamel on that tooth.
Got it. And we were talking, and the carbide it's much more operationally efficient, right?
Yes, and that's it. Right. Instead of taking off in dust particles, I liked, and again, this is for me, I wanted to be more efficient and speed the process up. I wanted to get rid of the hard stuff. And so I took it off in chunks. Now, stuff is spraying, and you may use, if you're using an isolation system or a rubber dam, or I never did, but my system was really good at it. But, we would get rid of that. She'd rinse them out. And then I would go back with my carbide or my diamond, and I would smooth things up and round everything and do my final preparation. So I was still using diamonds. I just was using it for the entire procedure.
And how much time does that save you to do it that way?
So it's been interesting. So when I was a trainer with the CEREC system, I was going in and helping I was a rescue trainer. So dentists that were struggling with it, I would go in and help them. So the first things I would do is I would go look at their scans, and immediately, and this is where we go back to the depth cutter, I could look at their scans and their preps and go, okay, I'm just going to tell you underprepared it. I wasn't there to be, I was just trying to help them understand that part. And then the other was I would also watch them do they would do a live one on a patient. So they would have a patient come in and they would do a crown prep, and I would watch that, and then I would check their scans and how they were designing it, and I was basically, the trainer on site for them. And there was one doc that literally spent an hour preparing this tube, and I just wanted to scream. Now, I know these young docs, they may be spending a lot of time doing that. And I just offer this as an alternative, as an option of you got to be careful. I said, you don't, because if you go get too aggressive, you're going to go pulpitooth, and you have to be very methodical in how you do it. But he just took so long. And to me, the long I always said, the longer I'm drilling on the tooth, the worse it is for the tooth, because we're heating that tooth up. That's why we use water, and we need that tooth that the nerve gets a little hyperactive to calm back down to baseline. And so if we're drilling, the less time we could drill on the tooth, the better. And so all I was doing was I was getting rid of all the hard stuff so I could go do at the end of my career, and for most of probably the last 20 years, I could do a crown prep in 10 to 15 minutes on a molar. On a premolar, um, I was much more efficient doing that than probably doing a filling on a premolar. But um, I'm just trying to improve my skills so that I was minimizing the patient's chair time, getting back to patient comfort. When they're walking out of my office in an hour for a crown prep, wow, that's pretty cool.
That's where my head was going. Were you talking about all this stuff? Like, I don't exactly know what you're doing, but I've been in those chairs, and I've been in the one where I'm in it for way too long. And I've been in the one where you get in and out, and I can tell you the in and out. Oh man, that whole dental experience, from not having to be in the waiting room, from getting seen to getting out to not having half your mouth numb. I mean, that whole experience changes your care for whether or not you just had to pay on the way out the door, whether or not your insurance took care of the whole thing.
Right. It just made for a much better um, workflow for me, because I could get up and go to another room, and my assistant could take over whether you're taking an impression or scanning or milling a crown in, whatever that is. I'm not required to be sitting there that whole time, and I could be more efficient. Or if I didn't have a patient, I could go sit down the hall. I could go maybe catch something on YouTube on investing, or maybe I'm catching something on clinical pearls or something. But I'm making the experience for the patient a whole lot better too. And I could see more patients doing the same great job. I could just see more people in less time. And that's really where you end up, you end up becoming more profitable down the road.
And that's really, I think, where you end up with that production, getting you to the point you can buy a practice. And then even it's funny, I just had a doctor running into the problem of, hey, we need some more profit. However, we don't have any chair time. So he came to me, and he wanted help. Should I buy a CEREC machine? And he's a few years away from retirement, so it's a big investment. And I remember sitting there, and I'm running the math, and I start asking him, like, okay, well, let's talk about how much chair time you're gonna free up. And then he started talking about how much chair time this whole process was going to free up for him. And my immediate response was, I don't care what it cost you. What I just heard out of your mouth was the patient is in the chair for an hour and a half less. And he's like, yes. And I'm like, you're doing it. Your patient experience cannot afford for you not to change your
Right.
process and go down this road, because nobody in their right mind these days wants to go in. And not that I actually knew what this stuff was till I'm asking questions, but nobody in their right mind wants to go in and then have to go back if they can get it all done right then and there. I mean, that's
Yeah, and we'll talk. We've got a whole other episode talking about digital workflows, and
uh,
but that was a game changer for me.
uh,
But also, I had to make sure that I was doing it the right way, and these what I've just explained really helped ensure that I was doing it efficiently, effectively, and I could do it in the parameters that made for in this case my CEREC unit. I could make a restoration that was going to last, but I did it because I wasn't waiting 20 minutes, 25 minutes for the anesthetic to work.
no, absolutely. Well, I think that's a great tease into the next
Yep.
episode. So Thank you all for tuning in again. And
Great.
next week, we'll be here to talk about digital workflows.
Sounds
I'll
great.
be here to ask questions. Scott, you'll be here to answer them.
Sounds great.
All right.